Good morning. Good morning, everyone. ഇന്ന് ബ്രംപ്ടൺ സമാജത്തിന്റെ 35ാമത് ഡോക്ടർ ലൈവ് ഷോ ആണ് ഇന്നിവിടെ നടക്കുന്നത്. പ്രിയപ്പെട്ട പ്രസിഡന്റ് ശ്രീ കുര്യൻ അല്പം തിരക്കായതുകൊണ്ടാണ് ഞാൻ ഇന്ന് പ്രിസൈഡ് ചെയ്യുന്നത്. ഇന്ന് നമ്മളോടൊപ്പം ഉള്ളത് ഡോക്ടർ രാജു ടൈറ്റസ് ചാക്കോ അവറുകളാണ്. അദ്ദേഹം CMC വെല്ലൂർ പ്രൊഫസറാണ്, ഓങ്കോളജി പ്രൊഫസറായിട്ട് വർക്ക് ചെയ്യുന്നു. ഇന്നത്തെ ക്ലാസ് സ്റ്റൊമക് ക്യാൻസറുമായിട്ട് ബന്ധപ്പെട്ടുള്ള സബ്ജക്റ്റ് ആണ്. അതോടൊപ്പം ഇന്ന് നമ്മുടെ അതിഥിയായിട്ടുള്ളത് റവറൻഡ് അനീഷ് എം ജോർജ് അച്ഛനാണ്. ഇന്നത്തെ മീറ്റിങ്ങിന് സ്വാഗതം ആശംസിക്കുന്നതിന് വേണ്ടി, ഡീറ്റെയിൽ ആയിട്ട് സ്വാഗതം ആശംസിക്കുന്നതിന് വേണ്ടി സമാജത്തിന്റെ എന്റർടൈൻമെന്റ് കൺവീനർ കൂടിയായ പ്രിയപ്പെട്ട ഷീല പുതുക്കേരിൽ അവരെ ക്ഷണിച്ചുകൊള്ളുന്നു.
Good morning, good evening, and namaskaram to those who are watching and listening to us through different social media like Zoom, Facebook, YouTube, and a warm greetings to all of you from Brampton Malayali Samajam, Ontario, Canada. ഇന്ന് നമ്മുടെ 35ാമത്തെ സെഷനാണ് ഡോക്ടർ ലൈവ് പ്രോഗ്രാമിൽ നടക്കുന്നത്. Let me first of all thank our Almighty God for enabling us to come this far having the sessions. Medical, Ayurveda, homeopathy, nutrition and medical research മേഖലയിലുള്ള മഹാമനസ്കരും പ്രഗത്ഭരുമായ പല ഡോക്ടേഴ്സിന്റെയും കാരുണ്യവും സന്മനസ്സും കൊണ്ട് BMS ഡോക്ടർ ലൈവ് പ്രോഗ്രാം കണ്ടിന്യൂ ചെയ്തു പോകുവാൻ സാധിച്ചു. ഇന്ന് നമുക്ക് ലഭിച്ചിരിക്കുന്നത് വളരെ പ്രഗത്ഭനും പ്രസ്റ്റീജിയസ് ഇൻസ്റ്റിറ്റ്യൂഷനിൽ നിന്നും ഗ്രാജുവേറ്റ് ചെയ്തതും ഇന്നും അതേ ഇൻസ്റ്റിറ്റ്യൂഷനിൽ സേവനമനുഷ്ഠിക്കുന്നതുമായ ഡോക്ടർ രാജു ടൈറ്റസ് ചാക്കോയാണ്. എന്റെയും കുടുംബത്തിന്റെയും അടുത്ത സുഹൃത്തും കൂടിയായ ഡോക്ടർ രാജുവിനെ ഇൻട്രൊഡ്യൂസ് ചെയ്യുന്നതിൽ അതിയായ സന്തോഷമുണ്ട്. ഡോക്ടർ രാജുവിന്റെ ക്രെഡൻഷ്യൽസിനെ പറ്റി സംസാരിക്കുന്നതിന് മുൻപായി CMC വെല്ലൂർ എന്ന മഹാസ്ഥാപനത്തെക്കുറിച്ചും അതിന്റെ ഉത്ഭവത്തെക്കുറിച്ചും പറയാതെ പോയാൽ അതിൽ കുറവായി ഞാൻ കാണുന്നു. നിങ്ങളിൽ പലർക്കും അറിയുന്നത് പോലെ അത്രയ്ക്ക് കേട്ടിട്ടുള്ള ഒരു ശ്രേഷ്ഠ മെഡിക്കൽ സ്ഥാപനമാണ് CMC ക്രിസ്ത്യൻ മെഡിക്കൽ കോളേജ് വെല്ലൂർ. ഏത് രോഗവും ട്രീറ്റ് ചെയ്യാൻ പല ഹോസ്പിറ്റലുകൾക്കും ഡോക്ടർമാർക്കും സാധിക്കാതെ വരുമ്പോൾ അവസാന കണ്ണിയായിട്ട് പല ആൾക്കാരും ചെന്നെത്തുന്ന ഒരു സ്ഥാപനമാണ് അത്. അതുപോലെ തന്നെ ലോകത്തിലേക്കും ബെസ്റ്റ് മെഡിക്കൽ കോഴ്സ് പഠിക്കുവാനും ബെസ്റ്റ് മെഡിക്കൽ സേവനം കിട്ടുവാനും വാല്യുബിളായ സെക്കൻഡ് ഒപ്പീനിയനു വേണ്ടിയും പോകുന്ന ഒരു മെഡിക്കൽ സ്ഥാപനം കൂടിയാണ്. All the graduates of CMC will agree with me in one voice as we all consider this as our greatest privilege, blessing and honor to study and work in CMC. And I thank God for enabling me to be a graduate of CMC and to know Dr. Raju from my college days. We also fondly remember the founder, Ms. Ida S. Khadar, whose vision lately became to a great mission institution. Ms. Ida Scudder happened to be in India with her dad, being a missionary doctor in the 1850s. And one night, as a young girl, Ida witnessed 3 deaths in one night. 3 moms and their 3 newborn babies died during childbirth because there was no lack of female doctor, and her dad was rejected to get help by their families. With that burden, she returned to US, completed her MBBS studies, and came back to Vellore and started a school for training female doctors and nurses in 1900. Later, this great institution grown to be the best training institution to the world-class level. The motto of this institution is not to be ministered unto, but to minister. ആ സന്ദേശത്തിൽ അടിയുറച്ചു നിന്നുകൊണ്ട് നിസ്സഹായരായ രോഗികൾക്കും അവരുടെ കുടുംബങ്ങൾക്കും കാരുണ്യത്തോടും സ്നേഹത്തോടും ശുശ്രൂഷ ചെയ്യുന്ന ഒരു മഹൽ വ്യക്തിയും ഫാമിലിയുമാണ് ഡോക്ടർ രാജു ചാക്കോയുടേത്. So I consider this as my honor and privilege to introduce Dr. Raju Titus Chacko to all of you. Dr. Raju had his preliminary schooling in northern parts of India like Missouri and Kalimpong. Then he joined Loyola College, Chennai in BSc Physics. After that, in 1979, Dr. Raju joined CMC Vellore for MBBS, and also he did his MD from there. Later, he completed his medical oncology training at the Royal Adelaide Hospital, South Australia. His interest is solid tumor oncology, specifically gastrointestinal malignancies. He also worked at various and higher capacities at Chitram, Chittoor CMC campus as the first associate director of CMC, recently in Dhaka, Bangladesh, and again back to CMC Vellore. Dr. Raju also had traveled all over the world in regards to his works and studies. Currently, he is working as professor and head of the medical oncology department at CMC and settled in Vellore too. Dr. Raju is married to Dr. Selva Titus Chacko, who is also a graduate from CMC Vellore, and she had held many higher positions, including former Dean of College of Nursing Vellore and Registrar and so on. Currently, she is the Dean of College of Nursing at Gulf Medical University, Dubai. I was fortunate to be Selva's close friend and classmate at CMC, and till now we cherish our friendships. They are also blessed with 2 children and 2 grandchildren. Their daughter Tina is doing her MDS in Dubai with her husband Nick and children, and their son Rohan completed his MBBS and currently doing his fellowship in CMC. With great pleasure and honor, let me welcome Dr. Raju Titus Chacko to our 35th Dr.Live program. We also have a guest speaker for today, Reverend Anish George Padikamanil, and he is currently the priest at CSI Toronto Church. Parish ചുമതലകളും ബിസി ഷെഡ്യൂളുകളും അച്ഛന് ഇന്ന് ഞങ്ങളോടൊപ്പം വന്ന് ഈ സെഷന് അനുഗ്രഹിക്കുന്നതിൽ ഞങ്ങൾ വളരെ സന്തുഷ്ടരാണ്. On the behalf of the Brampton Malayali Samajam, I extend our hearty welcome to Reverend Anish George. I also take this opportunity to welcome our chair, Binu Joshua, and also Biju Kurian Prakanam, our BMS president, who is our efficient leader and backbone of the Samajam. I also welcome Mr. Saja Human, who is also an active member and the vice president of BMS team, and Sanjay and all the BMS team members. Cancer and the മാരക രോഗം ഈ തന്നെ വരെ ഒരു ഭയാനകമായ രോഗമായിട്ട് തന്നെ ശേഷിക്കുന്നു. മെഡിക്കൽ സയൻസ് ഇത്ര കണ്ട് വളർന്നിട്ടും ഇന്നും പല ക്യാൻസർ രോഗത്തിന് കംപ്ലീറ്റ് റിക്കവറി ഓർ ട്രീറ്റ്മെന്റ് കിട്ടിയിട്ടില്ല. ഈ അവസരത്തിൽ ഇന്ന് നമ്മളോട് ഡോക്ടർ രാജു സംസാരിക്കുന്നത് സ്റ്റൊമക് ക്യാൻസർ എന്നതിനെ പറ്റിയും അതിന്റെ ട്രീറ്റ്മെന്റുകളെ കുറിച്ചാണ്. As many of us are eagerly waiting to hear from Dr. Raju Chacko, without any much delay, I welcome once again Dr. Raju, and also I welcome all the listeners and those who are watching us through different media. A warm greetings to all of you and have a great session. Thank you.
Thank you, Sheila Madam, for the detailed introduction about doctor and the hospital, everything. And now I invite Reverend Anish M. George, Achan, please say a few words.
ദൈവനാമത്തിൽ എല്ലാവർക്കും സ്നേഹവന്ദനം. ബ്രാംപ്ടൺ മലയാളി സമാജത്തിന്റെ നേതൃത്വത്തിൽ നടത്തപ്പെടുന്ന ഈ ഡോക്ടർ ലൈവ് പ്രോഗ്രാം ഇതൊരു ബോധവൽക്കരണമാണ്. യേശുക്രിസ്തു പറയുന്നത് രോഗികൾക്കല്ലാതെ വൈദ്യനെ കൊണ്ട് ആവശ്യമില്ല എന്ന് വെച്ചാൽ ഇഫ് യു ആർ സിക്ക് യു ഹാവ് ടു അപ്രോച്ച് എ ഡോക്ടർ എന്നുള്ളത് തന്നെയാണ് അതിനർത്ഥം വരുന്നത്. ഹെൽത്ത് അവയർനെസ് ഇസ് എ ഡിവൈൻ വർക്ക്. ലെവിറ്റിക്കസ് ചാപ്റ്റർ 13 പറയുന്നത് രോഗം വരുമ്പോൾ നമ്മള് സൂക്ഷിക്കേണ്ട മാർഗനിർദ്ദേശം അവിടെ പറയുന്നത്. ലെവിറ്റിക്കസ് ചാപ്റ്റർ 13 പറയുന്നത് ഹൗ ടു യൂസ് മാസ്ക്, സോഷ്യൽ ഡിസ്റ്റൻസിങ്, 14 days ക്വാറന്റൈൻ, എവറിഥിങ് മെൻഷൻഡ് അറ്റ് ദെയർ. നമ്മളപ്പോ അതിനെക്കുറിച്ച് ഒരു അവയർനെസ് നൽകുമ്പോൾ നിങ്ങൾ ഈ മലയാളി സമാജം ചെയ്യുന്നത് സാമൂഹിക പ്രവർത്തനം എന്നതിലുപരിയായിട്ട് ഒരു ദൈവിക പ്രവൃത്തിയാണെന്നാണ് ഞാൻ മനസ്സിലാക്കുന്നത്. ഡോക്ടർ രാജു ഇന്ന് നമുക്ക് ബോധവൽക്കരണം നടത്തുന്നു. ഞാൻ അനേകം ക്യാൻസർ രോഗികളുമായിട്ട് ഇടപഴകുവാനായിട്ട് എനിക്ക് സാധ്യമായത് കോട്ടയം കഞ്ഞിക്കുഴി ദേവാലയത്തിന്റെ ഒരു ഗൈഡൻസ് സെന്റർ ഉണ്ട് കോട്ടയം മെഡിക്കൽ കോളേജിനോട് ചേർന്ന്. ആ ഒരു ഗൈഡൻസ് സെന്ററിനോട് ചേർന്ന് എനിക്കങ്ങനെ ക്യാൻസർ രോഗികളുമായിട്ട് ഇടപഴകുവാനായിട്ട് സാധിച്ചിട്ടുണ്ട്. അവർക്ക് അനേകം പേർക്ക് ആശ്വാസം നൽകുവാനായിട്ട് സാധിച്ചിട്ടുണ്ട്. അപ്പോൾ തീർച്ചയായിട്ടും ഈ വരുന്ന ഒരു വലിയ പ്രോബ്ലം ഈ ക്യാൻസറിനെ കുറിച്ചുള്ള അറിവില്ലായ്മയാണ് പലപ്പോഴും പലർക്കും ഇത്രയും പ്രശ്നപൂരിതമാക്കുന്നത്. തീർച്ചയായിട്ടും ഇതുപോലുള്ള ബോധവൽക്കരണങ്ങള് അത് അങ്ങനെയുള്ളവരെ ഒന്ന് അവർക്കൊരു എന്താ ജീവിതത്തിൽ ഒരു പ്രത്യാശ നൽകുന്നതാണ്, അല്ലെങ്കിൽ ഇതിനെ ഒന്ന് തിരിച്ചറിയാനായിട്ട് ഒരു നല്ല സമയമാണെന്ന് ഞാൻ മനസ്സിലാക്കുന്നു. ഡോക്ടർ രാജു ആയിട്ട് എനിക്ക് അത്രയും പരിചയമൊന്നുമില്ലെങ്കിലും വെല്ലൂർ CMC ആയിട്ടുള്ള ഒരു ബന്ധം ഞാൻ പറഞ്ഞിരുന്നല്ലോ. അപ്പോ ഇത്രയും സമർപ്പണമുള്ള ഡോക്ടേഴ്സും നേഴ്സസും വർക്ക് ചെയ്യുന്ന, അല്ലെങ്കിൽ ആരോഗ്യ പ്രവർത്തകർ വർക്ക് ചെയ്യുന്ന ഒരു സ്ഥലമാണ് CMC വെല്ലൂർ എന്ന് പറയുന്നത്. വളരെ സമർപ്പണമുള്ള ആളുകൾ അവിടെ വർക്ക് ചെയ്യുന്നു. അതുകൊണ്ട് ഡോക്ടറുടെ സാന്നിധ്യം എനിക്ക് വളരെ സന്തോഷമുണ്ട്. മലയാളി സമാജം നടത്തുന്ന ഈ ബോധവൽക്കരണം മൂലം ദൈവം നിങ്ങളെ എല്ലാവരെയും അനുഗ്രഹിക്കട്ടെ എന്ന് പ്രാർത്ഥിക്കുന്നു. എന്നെ ഈ ഒരു ഡോക്ടർ ലൈവിലേക്ക് ക്ഷണിച്ച മിസ്റ്റർ കുര്യൻ പ്രക്കാനം, അതുപോലെ ജോസഫ് പുന്നശ്ശേരിൽ, അതുപോലെ ഷീല പുതുക്കശ്ശേരിൽ, അതുപോലെ ഉമ്മൻ ജോസഫ് സാക് എന്നിവരോടെല്ലാവരോടും, നിങ്ങളോടെല്ലാവരോടും നന്ദി അറിയിക്കും. ദൈവം നിങ്ങളെ എല്ലാവരെയും അനുഗ്രഹിക്കട്ടെ. എല്ലാ ആശംസകളും ഞാൻ നേരുന്നു. താങ്ക് യു.
Thank you, Cha. Thank you. Now I invite Dr. Raju Titus Chacko for today's session. Welcome, Doctor.
Thank you so much for inviting me to this program. I am really honored. Sheila, thank you so much for all those kind words. I don't know whether I actually deserve any of what you said, but thank you anyway. Can I share my screen and then we can get started? Okay, yeah.
Doctor co-host permission തന്നിരിക്കുന്നു.
Yes, okay, yeah. I have now been able to. Let me just. Can you see my screen? Can you see my screen?
Yes, I can. Sheila, can you confirm?
Yes, we can see it.
Great. Okay. So today, my task is to kind of give you a flavor of what is going on in the field of oncology with regard to stomach cancer. Firstly, let me, just show you where and what we're really talking about. So, when we put food into our mouth, it goes down a long tube, which is called the esophagus, okay? And this then enters, if you can see my arrow, it's showing you where it goes into a big bag, okay? And this bag is called the stomach. Now, in normal parlance, when we say stomach, we often mean the whole of the abdomen, okay? The whole of the belly, if you may. But actually, the stomach is this big bag, which is at the end of the esophagus. And from the esophagus, the food which is, kind of churned in the stomach and mixes with all the juices, digestive juices from the stomach, goes into the small intestine through a small portion which is called the duodenum. And that's this part that we can see. It goes behind. So that's why, it's shown in this line diagram like that. But, it's shown in a little more diagrammatic way on the right. So, the stomach has got several parts to it. So the part where the esophagus meets the stomach is called the cardia. Okay. And then the part which is above that is often called the fundus. The larger part of the stomach is called the body. And then just before it enters into the duodenum, it's called the pylorus. Okay, and the pyloric antrum is there, and then the pylorus itself, and then it goes into the duodenum. Now, we can, go into great detail here, but, suffice for us to know that the stomach is, when we look at the, each part of our body, we realize how wonderfully we are made, somebody has created us in such a way that each part of our body is so important. And we can see here how the stomach is made, and the structure of the stomach is so interesting. So you can see here a cross section of that body of the stomach that I showed you. And you can see, the part where the food comes in contact, that's the inside of this bag that we can see, is called the mucosa. Now the mucosa is kind of folded. And you can see one of those areas of folds that you can see there. So you see the surface area of the stomach is much, 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 much larger than what we normally see and what actually fits in our belly. And each one of those areas is like a deep well, which is covered by cells. And these cells have several functions. One of those functions is producing the gastric juices, which contain digestive enzymes and acid, so that our food is, nicely digested, and then it makes it easier for the rest of the intestine to absorb. And that's how, we have our nutrition for our daily work. In addition, the stomach produces a very important substance, which is called intrinsic factor. Now, this intrinsic factor is very important in the sense that it helps in the absorption of a vitamin, which is very important for our body, called the vitamin B12. So, just remember these things for now, because as we go further, we'll understand why these are important. Now, when we talk about cancers, cancer is, everybody uses it very, very loosely, but actually it's a whole canopy, if you may, of diseases that may occur. And even if you look at, just the cancers of the stomach, there are several types. And although, people just tend to kind of lump it together, for us, when we look at a patient, we can see that what everybody else calls cancers of the stomach may mean maybe about, say, 20 or 30 different diseases. Okay. Now, the most common of these are what is called the adenocarcinomas. But there may be other rarer tumors called the gastrointestinal stromal tumors, neuroendocrine tumors, including something called a carcinoid tumor. There could be lymphomas of the stomach. There could be squamous cell carcinomas of the stomach, or there could be small cell carcinomas or leiomyosarcomas of the stomach as well. Now, one of the things that we need to understand is that the process from which one finally develops a malignancy or a carcinoma may take several years. So although one may be diagnosed with the cancer in 2021, the process by which that cancer started might have happened, 5 or 10 years ago. And that is when the first, kind of insult happened to that one cell in the stomach. And that cell then had a mutation in it. And that mutation caused that cell to replicate without control. And later on in 2021, 10 years later, that cell has made multiple, it's kind of multiplied several times, and it's become the size of what is now visible or has made symptoms to call it a carcinoma of the stomach. So you see, if you really think about it, you probably had 5 or 10 years time to actually stop this process if we could stop it. And that is very important to understand when it comes to, cancers of any organ in the body for that matter. Let's just talk a little bit about statistics, okay? So here I have a little picture of the number of new cases of cancers in 2020. Okay, this is from data from what we call Globocan. It's an organization that collects data about cancers all around the world. And you can see here that you have about 1 million cases of stomach cancers, come. That is new stomach cancers in a year, 1 million in the world. Okay, and if you look at it by sheer numbers, it's about the 5th in the in the descending order of cancers. Okay, 5th of the number 5 in the cancer list of the number of new cases that happen every year. Now, again, this picture, I just want to draw your attention to the stomach cancer part of it, which I'm showing you here. And you can see here, if you look at it, the males, if you look at any one of these, the males seem to be, having more stomach cancers than the females. So if you look at here, stomach cancer 15.8, okay, here. And this is per 100,000, okay, and this is worldwide figures. While in women, it's only about 7 per 100,000. And we'll come to the reason why that is, or at least what is thought to be the reason for that a little later on. Okay, and again, some more statistics here. This just tells you something about the cause of death, okay? And here you can see stomach cancer, the incidence is, this is males and females put together, and this is age standardized. So about, let us say that you get about 11 stomach cancers per 100,000 people. And of this 11, 7.7 or almost 8 people die every year. Okay, so 11 new people develop stomach cancers per 100,000, and of these 8 die every year. So it's pretty deadly disease. Most of the people who are diagnosed with stomach cancer die within the year. And that's the important thing about this that we need to take away from this. So if you just look at, the cancer statistics, it differs, the incidence of this cancer differs wide. And I have another picture to show you globally, but this, diagram, puts it very nicely. Now, India and even North America, if you look at it, the numbers of cancers, especially, gastric cancers, are not very high, okay? So we are talking about an incidence of, like I said, 5 or 7 per 100,000. This is in both men and women. But there are some countries like Japan or Korea, or, some countries in South America, for example, where the incidence may be much higher, something like, 30 or 40 per 100,000 people as well. Yeah, and this kind of shows it kind of nice. You see the darker blues are the places where the incidence is double what we see in Canada or India. Okay, and as the intensity of the blue comes down, you can see that there can be areas in the world where there's hardly any gastric cancer. So this kind of suggests to us that there may be a geographical reason why people kind of develop this malignancy as, as different from the places where you don't have this malignancy. Another thing that we have noticed over the years, say, okay, so this is, just line diagrams from different races, okay, over a long period of time, 2000 to now, almost 2020, and this trend goes on. This is up to 2014 that I've shown in this line diagram, and you can see that the incidence of stomach cancer seems to be showing a kind of a lowering trend. The trend shows that the number of stomach cancers have actually decreased over the years. And again, we'll come to some of these reasons as to why this may be so as we go on. Okay, so then let's now talk about some of the reasons why one gets stomach cancer, some of the risk factors, if you may. And we can also, talk about what we might do to try and prevent it. If you know what are the risk factors, maybe we can, control some of these risk factors and help us, which might then help us to prevent this malignancy. So here on this page, I have a list of some of the risk factors which are well known in stomach cancer, but which we really can't do much about. As we grow older, for example, stomach cancers become more prevalent. If we are a male, then the stomach cancer is more prevalent, it's double what women get. Ethnicity, if we belong to certain ethnic groups, like for example, the African Americans in the US, the incidence of stomach cancer is much more. In India, for example, in some pockets like the Northeast, the stomach cancers are much more as compared to, say, Central India. And maybe there are pockets in Kerala and in Tamil Nadu where there are higher incidence of stomach cancer as well. Geography perhaps plays a part in the cause of this thing. And sometimes you can have a hereditary type of stomach cancer, which is, and some of these are well known, like the CDH1 gene mutations. One of the causes of stomach cancer is Helicobacter pylori infection. Now, the World Health Organization has said that H. pylori is a carcinogen of group 1, which means it's a definite carcinogen. We know it causes gastric cancer. And it causes a particular type of gastric cancer, which is called the intestinal type. And it is well known that those people who are infected with H. pylori tend to, have a progression over many years, because this bacteria kind of destroys the lining of the stomach, producing what is called atrophic gastritis. And this then, gradually progresses to what we call dysplasia, or a change in the way that the cell actually looks. And this later on goes on to become a carcinoma. Now, there are many studies which tell us that this association is true and correct, and our assumptions regarding H. pylori are true, because we now know that if I treat H. pylori, then, I might actually reverse this process of carcinogenesis, okay? So, I previously showed you that slide, where it takes 5 to 10 years sometimes for a carcinoma to develop from the first insult. Now, if I catch somebody in between with an H. pylori infection, they might be able, then I might not, then I might be able to actually prevent people from getting this if I can treat this. And this infection is easily treatable. We can test for H. pylori now, and there are some easy ways and some more difficult ways. For example, this particular bacteria, which is called H. pylori, breaks urease inside the stomach to carbon dioxide. Okay, so if you give somebody labeled urease, carbon, if you label the carbon with some radionuclide and give it in the carbon dioxide that is breathed out, if it contains, this labeled carbon, okay, something has broken the urease inside the stomach. And that may be an easy way of testing for H. pylori. Sometimes you can do a stool test and look at a particular antigen of H. pylori. But the most common way that it is diagnosed is by, doing an endoscopy, which is putting a tube down through your mouth, through the esophagus, into the stomach, and actually doing a biopsy and looking under the microscope. As I already alluded to, H. pylori can be eradicated with treatment, and there is enough evidence today that this may reverse the carcinogenesis that we might have. Now, another cause which is seen, oh, by the way, one of the reasons why we believe that the incidence of gastric cancers is actually reducing in many countries of the world, maybe because there is less H. pylori. Now, in the past, when there were no refrigerators, food, which might not have been really edible, might have been consumed by many places. But over the years, all around the world, refrigeration has become easily available. And the incidence, therefore, of H. pylori has decreased. But while the H. pylori type of cancers have actually decreased, there has now come about a new problem, and that is the obesity-related, gastric cancers. Now, one might ask, what is this and why would obesity actually produce a cancer? Now, excess body weight has certainly been associated with the risk of gastric cancer. And there are several studies all around the world which tell us that, a BMI which is high, more than 25 kilogram per meter square, is definitely associated with an increased risk of gastric cancer. One of the things that is thought about is when you have obesity, there's a lot of fat inside the stomach, which then causes your gastric secretions to be pushed upwards into your esophagus. And to explain this theory, we notice that those gastric cancers that happen because of obesity tend to occur towards the area where the beginning of that esophagus is. Okay, so towards the area of the cardia is the place where these obesity-related gastric cancers develop. Now, diet is another reason, and this kind of is to be expected, isn't it? When something goes into your stomach, that's the thing that is most likely to cause cancer. One of the things that we noticed in very cold climates in the past, like for example in Iceland, I'm not very sure whether the same was in Canada, but say in Iceland, one of the things that they used to do to preserve meats was to cure it with very high salt. Okay, and then these were preserved there for many months, and those kind of tribes there, tended to have cancers. Now it's well known that people who have a very high salt diet, especially when they use it to preserve and cure meat and fish, there's a very high incidence of gastric cancer in those communities that develop this. I don't know whether, for example, in Kerala, where people use dried fish, very highly salted dried fish, whether that might be the reason why we see, a little higher incidence of this cancer in that group of people. And that might also explain why the cancers are higher in the northeast of our country as well. In Arunachal Pradesh and Nagaland and all, they preserve and cure meats and keep it for a long time in that kind of way. Now, the other compound that has been associated with this is the nitroso compounds, which are seen in processed foods, for example. Okay. And also seen in tobacco. Okay, so the nitroso compounds are seen in tobacco as well. Also, we know that alcohol is associated with gastric cancers, and the diet which is low in folates are associated with cancer. So it follows then that you could do, you could avoid high salt diets, okay, especially avoid the dried fish, which is highly salted. That would certainly be a preventative that you could possibly do. Are there anything that you could do positive? Sorry, yeah. Let me just talk about 2 or 3 more risk factors. Smoking, okay, well-known risk factor and increases by a factor of 1.5 in men. Okay, 18% of all the gastric cancers in the world are attributed to smoking. And interestingly, if you stop smoking, your magnitude of risk seems to diminish, say, with levels coming back to what is there in the normal population after about 10 years. So my advice, if you're smoking, stop now. If you haven't started smoking, don't start. There are many other factors known. An Epstein-Barr virus has been noted to be one of the causes. People who come from a low socioeconomic status, again, I don't know whether it's a lack of refrigeration or eating certain foods, which might be the cause of it. People who've had previous gastric surgery, for example, tend to have a higher incidence of gastric cancer. If you've been radiated in the abdomen for some other disease, like, for example, in childhood, if you had a lymphoma, it is possible that you could get a gastric cancer later on. So, are there certain protective factors, things that you could do to, prevent yourself from getting gastric cancers? There are good epidemiological studies which show that fresh fruits, vegetables, and a diet with high fiber is protective against gastric cancers. And case control studies from Europe, Asia, and North America, and a pooled analysis of multiple such studies have consistently shown that there is a benefit for for taking this kind of food, being protective against gastric cancers. Now, there are some studies which suggest that, patients who are on low-dose aspirin for many other diseases, like, for example, as an antiplatelet agent, may also have some, taking this drug may be protective. There are studies that are currently going on as well. So I'm not advocating that everyone goes home and starts taking aspirin right now, but certainly there's some indication that these kind of studies, that this kind of drugs may actually be protective. Now, everybody is asking this question, why is it that women have less gastric cancer, half the rate of gastric cancers than men? And it's now been thought that part of this may be the female hormones per se, and there may be a protective, and these may be actually playing a protective role in women. You see, otherwise, men and women are actually exposed to the same environment everywhere. Whether it's geography or genes or whatever it may be. But they seem to have half the number of, gastric cancers that as compared to men. And it must be the reproductive hormones that are helping them to be protected against the gastric cancers. Okay. So how do we find out that one has gastric cancer? There are several that are done in many parts of the world, like Korea and all. You might actually, have an endoscopy done. Just like, you are screening mammograms for breast cancer, or, screening CT scans for lung cancer. In many parts of the world, they do screening endoscopies. For example, in Korea, it's recommended that any male over the age of 50 years old to the age of 70 years old must have an endoscopy every 2 years. Okay, and there are several other tests that one might do to look for gastric cancers. Now, many of them, except for the endoscopy or the double contrast radiography, are really not done most places except for research reasons. So as I already alluded to, in Korea, 40 to 75-year male has an endoscopy every 2 years. And this is the case in many countries in very high-risk population. But in many countries, including the US, Canada, and India, there is no prescribed screening, except if you belong to a very high-risk population. So how do you know that one has stomach cancer? How do you suspect that one has stomach cancer? So, in this table, I've actually shown the symptoms that more than about 18,000 patients with gastric cancer presented, okay, to the hospital with. And you can see that about 62% of them presented with weight loss as their symptom, okay? And that is understandable, isn't it? Because the stomach is a very important part in the digestive process in the human being. And if that doesn't work so well, you can imagine why the person is, has a weight loss. He doesn't feel like eating, he's got dyspepsia, he feels full very easily. And those are the reasons why he doesn't eat, and that causes him to lose weight. Abdominal pain is a very common symptom in about half of people. About 1/3 of them complain of feeling nauseated. About 1/4 of them complain that when they swallow food, they feel that the food is stuck and doesn't go down. About 1/5 of them complain of, passing blood in the stools, or black tarry stools sometimes. And others complain of some acid, ulcer type pain as well. Some people say, okay, I can feel a lump in the abdomen. Some people, complain that my abdomen is very distended, and that is often because of fluid that comes in the stomach. Sometimes the stomach gets obstructed or blocked, and then the person starts vomiting, is not able to take anything in, and that is a symptom that's a problem. Okay, and like I'd already alluded to, we use this particular thing called an endoscope, which we can put into the stomach, and we can, the optics currently is so good that we can identify, we can actually see a very magnified view of the stomach, and we can see even very tiny ulcers that might be there. We may use imaging like PET CT scans or MRI scans or a CT scan alone to actually tell us whether the cancer is only in one place in the stomach or whether it is already spread to other parts of the body. An endoscopic ultrasound is also a very good way of looking at it, because an endoscope will only see the surface of the stomach, isn't it? The mucus of the stomach can only be seen by the optics of the endoscope. But if you add an ultrasound to the tip of that endoscope, that ultrasound could tell you what is below that mucosal surface, and that's a very good new technique that is now available for us to see cancers of the stomach. Now, I just want to quickly go through this last part of my presentation where I want to tell you a little bit of what we call staging, and then quickly go through a few slides of the management of a patient with gastric cancer. Now, staging literally means for us, how far has the cancer really spread in the body? This may be a little complicated diagram, but if you look at these, it will tell you, you know, how far from the surface of the stomach, how deep has the cancer actually gone. Now, you see a T1 tumor has only gone up to a certain level down, while a T4 tumor has gone past the wall of the stomach and into the adjacent organs, like for example the aorta, which lies very close to the stomach, or the pancreas, which also lies very close to the stomach. Now, if it goes to the lymph nodes, which are, you know, around the stomach, we usually, you know, depending on the number of lymph nodes involved, we give that a number as well. You know, we call it N1, N2, or N3, depending on the number of lymph nodes that is involved. And if the tumor is actually spread beyond the lymph nodes, like for example, into the liver or into the lung, you know, in women, for example, into the ovaries, we might call that, you know, M1 disease or metastatic disease. Why do we stage patients like this? It's important because it helps us to prognosticate. It tells us, you know, what the survival of these patients are. And these curves, which are survival curves, are, you know, about people surviving with different stages of gastric cancer after an operation. Okay. So if you look at these, you know, this red curve, for example, here, if you got a stage 4 disease and you've had a surgery, you hardly survive a few months, you see. 50% of the patients are dead in 3 months, and 100% of them are dead by 12 months. While if you have just stage 1 disease, your chance of survival, you know, for 5 years or 6 years is a good, very close to 100%, provided you have the right treatment. So this is in spite of treatment. You can see how bad we have. And unfortunately, this has not changed much over the last 25 years. Unfortunately, I repeat again, this graph has not changed much in the last 25 years. Do we have reason to hope? Yes, but we haven't reached there yet. Surgery still remains the most important treatment for gastric cancer. We sometimes have to remove the whole stomach, which is called a total gastrectomy, or we may have to remove the part of the stomach, which is called a partial gastrectomy, to remove the cancerous part. Chemotherapy and radiation is often given in addition to surgery when the intention is to cure the patient. But it may also be given for palliation, that is to control the symptoms of the disease when a curative surgery is not possible. Now, you all might have heard about what is called the Human Genome Project. Okay, this was conceived in 1985 and involved, sequencing the human gene, DNA. Okay, and this was started. It was completed in 2003. It was what do we call it? Moonshot, as we might call it. Now, along with this sequence human gene, we also have We've also been able to sequence, different cancers. So that was another project that went side by side. Okay, so many of the cancers like gastric cancer, breast cancer, etc., have now also been sequenced. The genes have been sequenced. So on the one hand, we have the reference mosaic of the human genes, and we have the cancer genes on the other hand, and we can compare these two to see what is the difference. And we are then now able to look at certain DNA alterations in cancers, DNA fingerprint, if you may. And this DNA fingerprint, we have now learned, is fairly consistent in many, many malignancies. We are also able to characterize cancers depending on the fingerprint. So we now no longer call the cancers depending as to where they started, but looking at the DNA fingerprint of the cancer, we would call it, an EGFR mutated or a HER2 mutated, cancer. Okay, and that helps us to think about it in a different paradigm altogether. So, for example, we may now be able to predict which drugs may be beneficial in particular tumor types. This is called targeting. And several targetable alterations are now known. And we now use this in the clinic to the benefit of patients, including those with stomach cancer. Many patients are alive today after finishing their surgery and their chemotherapy, and they live for several years. Okay, but you must remember that there are certain lifestyle changes that are required once you take this big bag into which all the food that we eat goes into, okay, and which we take for granted. Okay, you must remember that once this bag comes out, only a very limited amount of food can actually be eaten, because the moment you eat more than the tube can fit out, it will come as vomitus. Hence, it's very important for these people to eat very small but frequent meals so that they are so that they get adequate nutrition. Remember that when you take off the stomach, there is no intrinsic factor. So patients need injectable vitamin B12. Although now there's, the possibility of giving this vitamin B12 as a nasal spray. It's also important to remember that, once somebody has a cancer, it's very important to have regular surveillance so that you look for other areas in the body which might have cancers as well. And they need to abstain from alcohol and tobacco. Palliation is very important in advanced disease to make living with cancer bearable, pain relief, reducing the distress because of a distended abdomen, providing social supports, feeding, hospice care, like we say, putting life into the days, months, or years that a patient has. So thank you very much for a patient hearing. I'd be very happy to answer any questions if you may have. I'm really sorry if this talk, was a little detailed, if you may. Thank you, and over to you.
Okay.
Thank you, doctor. Thank you.
Doctor, on the screen sharing on the stop,
Okay. Is that all? Is it done, or you are now screen sharing? Stop share. One second. Yes. Done.
So what did this guy end up saying? He talked to the manager on Monday.
Sanjay, please mute. Or is not talking.
So they said, what do I do? He said, I can't help you with the manager.
Any questions? നമ്മളോടൊപ്പം ഡോക്ടർ ജോഷി ലൈനിൽ കാണുന്നുണ്ട്. Any questions?
So after making a similar presentation at a place, I was told that, you know, I'd flummoxed the audience so much that they didn't have anything to ask.
I'll ask you your first question, sir.
Please, yes.
So what percent of these cancers are actually genetic, that you're born with a genetic mutation and then your lifestyle gets added to it and then you actually succumb to it?
So for gastric cancers, I would say that, you know, it'll be less than 10%. Where there's a known genetic factor which is causing you to have gastric. That's what's known. But, you know, having said that, there may be many things that we don't know about, you know, cancer susceptibility. And we often say that, you know, there's probably a susceptible individual on which you have an insult. And that's the kind of a second hit that a susceptible cell gets. And thereby, you know, that individual gets cancers. Now, it's not that all genetically susceptible individuals will go on to have cancer either. So what we don't understand is why it happens in some individuals and why it doesn't happen in others. For example, you know, not all smokers will get lung cancer or stomach cancer for that matter. But it's well known that 20% of people who have gastric cancers are heavy smokers.
Thank you.
Doctor, we have one question from the audience. I will read it. Drinking too much of caffeine causes any issues?
Not known as such. You might stay awake at night, but otherwise I don't know of any reason.
എനിക്കൊരു ക്വസ്റ്റ്യൻ ചോദിക്കാനുള്ളത്, ഈ സ്പൈസസ് ഉപയോഗിക്കുന്നത് നല്ലതാണോ അഴുക്കാണോ ക്യാൻസറിന്? ഈ നമ്മളെ കേരളത്തിൽ നിന്നൊക്കെ വരുന്നവര് ധാരാളം സ്പൈസസ് നാട്ടിലുള്ളപ്പോൾ ഉപയോഗിക്കും. നോർത്ത് അമേരിക്ക വന്നു കഴിയുമ്പോൾ സ്പൈസസിന്റെ ഉപയോഗം കുറയ്ക്കാറുണ്ട്. അത് നല്ലതാണോ അഴുക്കാണോ എന്ന് പറയാം.
So, you know, people have asked, for example, you know, is the cause of gastric cancer, you know, the spices, you know, the chili, for example. Is that the reason why? So then we should expect that in areas which have a very high chili consumption, for example, you know, in say Andhra Pradesh, that you should have a much higher gastric cancer, isn't it? But that's not the case. The case is that you have gastric cancer seen in certain pockets in the country, and we can't explain that by spice use per se. So spices, you know, may be good anyway, that help to make your food tasty. So I mean, I can't blame the spices for any cancers as of now. Yes.
I have a question. Is the heartburn anything a sign of any of these discomfort things?
Yeah. So, you know, dyspepsia and, you know, an acid type of pain, okay, it can be a symptom of gastric cancer. So, you know, today we have very good treatment for this. So if you are got, you know, like heartburn or something like that, treatment is available. And if that treatment doesn't solve your problem in a short duration, like a month's time, it's important for you to persist and see a doctor, get an endoscopy done to make sure that you're not sitting with a large malignant gastric ulcer. Remember that these cancers are very silent in their early stages. And that's a very unfortunate part. And somebody described it like a thief in the night, you know. So you know that a thief has come into your home and gone, when you see that the clock on your mantelpiece has disappeared in the morning, okay, but then the deed has already been done, and you can hardly do anything about it at that point. So picking it up early is certainly really, really beneficial. So if you have symptoms like a heartburn which is not going away, it is very important for you to go to the hospital rather than, you know, trying to treat it yourself.
Are these cancers PD-1 positive?
There is a subset of these cancers which are PD-L1 positive. So we do use immunotherapy and chemotherapy in those sort of patients who are inoperable and who are PD-L1 positive. Yeah, I mean, but that percentage will be something, you know, again around about 10%, maybe up to 20% as well.
Sorry, doctor, ഒരു question കൂടെ ചോദിച്ചിട്ട് ഇപ്പൊ ഈ കോവിഡിനൊക്കെ ടെസ്റ്റ് ചെയ്യുന്ന പോലെ PCR ടെസ്റ്റ് whatever it is, അതുപോലെ ഏതെങ്കിലും ഒരു ടെസ്റ്റ് ഉണ്ടോ ഒരു മനുഷ്യന്റെ ശരീരത്തിൽ ക്യാൻസർ ഉണ്ടോ എന്ന് കണ്ടുപിടിക്കാനായിട്ട് മെഡിക്കൽ സയൻസിൽ എന്തെങ്കിലും ഉണ്ടോ?
Yeah, so at the moment we don't have any one test which can recognize whether somebody's got cancers in the body or not. Remember that cancer is not just one disease. It is, you know, so many diseases all over the body. But, you know, we are now recognizing that in our bloodstream, each of these cancers, you know, I was talking to you about the fingerprint, not the DNA fingerprint per se. Now that DNA fingerprint can sometimes be recognized by just taking a blood sample. Okay, and we can look at circulating tumor cells in them. So it may be possible for us to look at that, or look at, you know, some proteins which are circulating in the blood, and pick out. Today techniques like, you know, microRNAs are available, which we might be able to pick out some of these cancers. But today they are used more to kind of look at how patients with cancers are actually doing. So we can quantify these. And we can say, okay, his cancer is getting better or his cancer is getting worse. That's what it's being used for now. It hasn't yet reached the stage where we can, you know, do a blood test and tell you, you have cancer or you don't have cancer.
Thank you.
One more question I am seeing in the chat window. There is one question, I will read it. The questions is high salt and cheese like Lay's chips, pizzas, pasta, Tim's or McDonald's, Subway, sandwich, etc. Any suggestions? You know, is it good or bad? I think the question is like that.
So, you know, I tell my patients here, many of them come and complain to me that, you know, they have, they are very gaseous, you know, they come and complain to me that they're very gaseous. So I tell them, see, you know, gas is a natural byproduct of any digestive process that we have in the body. Okay. Now the food that you eat goes down, and some foods produce more gaseous compounds and others less. For example, if you have a fat, nice mutton biryani, you know, we all know that we tend to be more gaseous than at other times, right? Now, if you are very worried about that gaseousness, then it's better that you avoid the mutton biryani. But having said that, you know, all of us want to have a little mutton biryani every now and then. That's our quality of life. That's what we enjoy, isn't it? So everything done in moderation is good. And we need to be in control of that. So, you know, like a friend of mine told me once when I offered him some more mutton biryani, he said, look, I'm very happy with your mutton biryani. It tastes brilliant, but unfortunately my stomach doesn't like it. So that's how it is. So we have to think of ourselves as being an ecosystem where we've got the power to choose what goes into our mouth. Once it goes into our mouth, we have no power over it after that. Okay. So whether it is Lay's chips or pizza or pasta or whatever it is, maybe good to take once in a while, but you can't live on these things. And if you live on these, we'll face the consequences as we go on. What these consequences are, whether it is because of a dicky heart or whether it's because of cancer, one doesn't know as of yet, but all these are possibilities.
It's interesting you said that, because on the airplane, right, the food that they give you is the one that gives you less gas for obvious reasons. You don't want to have, plane full of people with gas issues.
Yes, right.
Raju, can I ask you a question about the different types of diets? But do you see the prevalence more in vegetarians or non-veg? And also the type of, the method of cooking has changed. And especially in these countries now, we are going to air fryer and the less amount of cooking with all these modern technologies. And also I know that eating meat, especially red meat, is also a prominent factor to cause cancer. What's your take about it?
Okay, so there's a lot of research, with regard to this. For example, we ourselves were involved in a huge research product, which is involving more than 4,000 women, okay, in our country here in India. We know, for example, the Gujaratis, are predominantly vegetarians. They would never eat meat, okay. While if you look at a state like Kerala or West Bengal, we wouldn't have a day where we wouldn't eat meat. So these are totally different, populations with totally different diets. But if you look at the prevalence of something like, say, colon cancer or breast cancer, there's no difference, okay? So it doesn't appear that lifelong vegetarianism necessarily protects you from any of these things. But I'll tell you, one of the problems with our study was we never asked the question to the Malayali as to what is the meat that he was eating? Was it fish or what was he eating red meat? That question we never really asked during our study. So I can't answer that. There is some data which suggests that red meat might produce changes, for example, in the colon. Okay. But we don't know whether there is any such interaction with the gastric mucosa per se.
Thank you, Raju.
Doctor, ഒരു ക്വസ്റ്റ്യൻ ചോദിച്ചോട്ടെ?
Please.
ഓർഗാനിക് ഫുഡിനെ പറ്റി ഉള്ള അഭിപ്രായം എന്താണ്? അപ്പം ഒരു പുതിയ ട്രെൻഡാണല്ലോ, everybody non-pesticide food, organic. Is it just a marketing or something?
I really don't have a comment on that. See, I think that there's certainly, a great deal of there's a great deal of, experimental work which suggests that many of the vegetables that we get have a higher content of pesticides in them. That we know. But what we don't know is what is that effect on, we tend to kind of naturally think that, hey, I'm eating pesticide and that's bad for me kind of thing. That seems to be a natural reaction to us. But, is there proof that really does us harm? That I don't know. Okay. Now, you and I don't want to eat kind of poisons. And therefore, if we can avoid foods that have poisonous substances in that is fine. But, on the one hand, you will eat organic food. And then on the other hand, you'll go and smoke. It doesn't make any sense to me there. So that's the kind of thing that we have to watch out for. Or, you will eat organic food to the extent that you are like 120 kilos. It doesn't make sense. Because then so you have to live healthy, whichever way you're going. Whether you're eating organic food or whether you're eating, food otherwise. You have to learn to be healthy, and that's the best thing that we can, suggest.
Doctor, 2 questions ഉണ്ട്. അതിനു മുമ്പ് it was a beautiful presentation. ഒരു MBBS ക്ലാസ്സിൽ അറ്റൻഡ് ചെയ്യുന്ന പോലെ ഒരു പ്രതീതി ഉണ്ടായിരുന്നു.
I was a bit worried that I was going to, make everybody little doctors.
Yeah, ഒരു 2 question. ഒന്ന്, what are the initial symptoms of stomach cancer? നമ്മൾ നോക്കേണ്ടത്. That is the first question. Second, are prebiotics and probiotics good for the gut?
Can I add one more question?
Sure.
Doctor, you said that for early detection, you advocate endoscopy, stool test, these 2 tests, I think, and any other symptoms. Actually, people are very afraid of taking this endoscopy because putting the tube through the mouth and all those things. Is there any other modern method of just like swallowing a pill or something like that with camera or something like that to conduct the endoscopic test? And out of all the tests, which test do you advocate to do first to detect an early cancer?
Okay, so if I may take the questions one by one. See, the first thing is, what you must understand is that, early gastric cancer hardly produces any symptoms. So the symptoms may be very subtle, in the sense that your body and you see that, you're suddenly getting, say, peptic ulcer pain, or, you're feeling unusual fullness. You would normally eat a certain amount of food, and you're suddenly finding that if I eat, say, 1/3 of that amount, I'm already full. Okay. And that kind of early satiety may be a symptom that you may have. When you have such symptoms, it is better you go to the doctor. Now, the second part of the question is about diagnosis. There's nothing as good as endoscopy today. That's the gold standard. Okay. Now, there are several people who, like you said, are, afraid of an endoscope. What do you do? Now, all the other tests that I mentioned, the blood tests and other things are only good in the academic settings where you're doing it as an experiment, when you're comparing it with the endoscope. So it's nothing as good as, putting an endoscope down and looking at it. Now, people say that you can do what is called a double contrast X-ray. That means, you swallow some barium and then they take X-rays, but it's never as good as doing an endoscope because you can't pick up early disease. You may pick up late disease, and then that doesn't benefit you, doesn't it? So it's better that you pick it up early, and for early disease detection, an endoscope is the best. Endoscope is now an outpatient procedure, and you don't even get admitted for it. You walk into the hospital and you come out, an hour later, go back home. So it's that quick. So in Vellore, per day, I think they do 150 of them.
Thank you.
Yeah, I think no more questions. It's 11:45. We have another meeting scheduled at 12 p.m. Thank you very much, Doctor. May I invite Vice President Umman Joseph for a word of thanks.
Thank you everyone for attending today's meeting. Especially, I would like to thank Dr. Raju Titus Chacko for giving us a detailed study report and make us all aware. As Sen mentioned, probably we are now is half doctors, but we don't want to be, because we want to go to the doctors whenever we have a symptom, as Raju suggested. Anyway, thank you very much for your detailed presentation, Dr. Raju, and it was a very good presentation, and people has a lot of doubts, and hopefully they all get some kind of clarification what they are looking. And then I would like to thank Reverend Anish Georgechan, CSAVIGA, for the introduction today, and also Achan's presence in this meeting. I would like to thank President Kurian Prakhanam for his leadership, and also his diligently looking for this Dr.Live programs and making this, as taking the effort to continuously doing this every week. Thank you, Kurian, for your efforts. And thank you, Sanjay, for all your technical supports. That's a live stream in Zoom and FaceTime. So thank you, Sanjay, for your efforts. Thank you, Sheila, for your vote of thanks. Sorry, for your welcome speech and giving us the details of what's everyone about. And special thanks to everyone who attended today from worldwide. I know people are watching from Middle East and also from India. So thank you all for attending today's Dr.Live program. Thank you all.
Thank you, Mr. Joseph. Once again, on behalf of Malayali Samajam, thank you very much, Doctor, for coming and patiently answering all the questions. And I hope a very good session. It's 11:47. If you have any, we can wind up.
Thank you very much for having me. Great to be with you.
Requesting everybody to please stay by. So visual meeting will be start in 10 minutes. There are a lot of VIPs coming.
Have a wonderful Vishu meeting.
Yes. Sure. And bye-bye. The Travancore Prince is coming, and the Mayor of Brampton, Minister of Ontario, and MPs, a lot of VIPs coming. We request everybody to please stay and support us. Thank you.
Bye-bye.
10 minutes, we can just start at the time. Early joining up.
So, Kurianji, Facebook Live stop.
Thank you. Thank you, Raju. Thank you, Raju.
Thank you. Thank you, Raju.